Welcome to Megaphone from Medvale Media. I'm Dave Self. This is the place where we invite big thinkers, innovators, and healthcare leaders to join us and share their thoughts, their perspectives, and the occasional rant about the ever-changing and dynamic world of healthcare. And today, really thrilled to have a full disclosure, a longtime friend, and someone that I have a great deal of respect for, Dr. Edward McEachern. And we're going to dig into a bunch of stuff that Edward and I have discussed over years. And today he's deeply engaged in bringing some of that to reality. So Edward, first of all, welcome to Megaphone. We're going to hand it to you in a second. Would you give us a little background of how you got from where you were as a young kid to where you are today?
Yeah. Thanks. Happy to be here, Dave. And it is actually a pleasure to be with an old friend. I grew up in Nashville, Tennessee, which is sort of the hotbed of sort of a node of innovation for healthcare. And got involved with that after I went to college at Emory and then did a master's in statistics at the University of St Andrews in Scotland, which was mostly beer drinking and golf playing, but somehow passed the test. And then medical school up in Cleveland and came back to Nashville after a pathology residency at UCSF and worked with HCA in two functions. One of them was with their quality resource group, which was learning how to take apart processes and make them work better. Work that Dr. Edwards Deming and Joseph Duran did in industry, and I did that in healthcare. The other is I worked as a lab medicine physician as a pathologist, creating the first hub and spoke pathology lab in the country with HCA. That was sort of a joint venture between a company that I work with and HCA. And I learned a lot about taking apart processes and putting them back together and making processes work for you. I got tired of my pathology colleagues. They're wonderful people, but they're not extroverts like I tend to be. And went back to a second residency in internal medicine. Probably the only guy who ever moved back to Cleveland. Maybe LeBron James did that too, but I did an internal medicine residency and a fellowship at the Cleveland Clinic. I then worked as a chief medical officer for the Ohio Blues. It's a very large plan,
Yes, it is.
and started the first Medicaid HMO in the country there with about 350,000 Medicaid members and a place called Metro Health Medical Center. And that was a wonderful experience. Moved to Cleveland. I moved to Boise in '97 and worked with a colleague and competitors at St. Al's, which is sort of an interesting place. That St. Luke's and St. Al's are the two big hospital systems in Boise, and worked there for a while, and then went to a private equity fund for a bit, where I bought and sold hospitals and created them de novo from ground up. Then in 2015, started as the chief medical officer for Pacific Social Health Plan, also a collaborator and competitor in the marketplace for health plans. And then in June this year, after failing retirement, uh, in June of 24, started as the CMO for the St. Luke's Health Plan. Love being at St. Luke's. It's a great organization. Have great friends here. Been working with these folks for 30 years. Um, the just culture makes it easy to do the work that we're going to talk about we're doing. So that's a brief history of where I got to and how I'm here.
So you took the normal path, is what you said.
The well-trodden normal path through
Yeah, yeah,
Cleveland. Yeah.
yeah, absolutely. Pathology, VC, whatever it takes.
Right.
Well, one of the things that we've discussed truly for years is how do we take the variability out of this? How do we put people, the consumer, the patient, the member, back in charge of their health? And how do we remove the barriers between the people providing the care and the people receiving the care? How do we take the friction out of the process? And that's something that you've been definitely committed to for the last decade or so in these roles. So share with us a little bit about what you're doing today, please.
Yeah,
And what
it's a
what attracted you to it too? Because you
it's
could have done a lot of things, including stay retired.
I don't know that I could have stayed retired. I think what I learned about that is that your wife's list becomes your list, and so it was good fun. No, it's been a lifelong pursuit. The idea is that what the health plan wants to do at St. Luke's is create hassle-free experience to connect people with affordable care. And then it ties into this mission that St. Luke's has in the 20 southwestern corners of the state of Idaho, which is to take care of the pathology and the health of the people that it serves. And so, in order to do that, we have to provide the right care at the right place at the right time and the right amount at the right cost. And that involves figuring out how all the pieces line up together and they create a chain of value. And if we want to do that in a smart way, we need to really understand first the pathology of the people we're looking at and fix the system so that it actually doesn't look as a vertical structure, but as a horizontal structure. How do we create a journey that a patient has through our system that identifies their need and then specifically meets that need at the highest efficiency possible? What you have to do there as a health system is that the people who present to us have different severity of needs. There are some people who consume $10,000 a month. I call them the frail folks, and they probably would benefit greatly from having a nurse and a doctor, ombudsman, move them through the system in a way that makes help. Some people have pathology in that group that's just bad pathology, and they're in the process of dying, and they need to die well. Other folks have had a catastrophic event, a car crash, or they have a heart attack, or they've got a cancer. All those are curable or survivable at this point. And they need a quick and easy journey through the system that is not complicated by barriers that we, in our attempt to provide good care, put up. And so, one of the things that we're doing for those large cases is we create a unit that is an ombudsman that is clinically adroit, that understands the needs of those people and can monitor their journey and help them with their journey across that enterprise. The next level down is a group of people who are at high risk. They spend maybe $5,000 a month, and they would benefit from that as well. But most of those people live in what I call service lines. So they have a hip problem or a knee problem, or they have a
Sure.
spine problem or oncology or whatever. And those service lines exist in a broad spectrum of places, and they need to work off of one clinically relevant protocol for those service lines. And so, one of the things that we're trying to do now is with hip and knee, with sepsis and with spine, we've got a good progress going at St. Luke's to standardize the care that we're giving and decrease unwanted variation that's not really clinically valuable. Variations is useful, but sometimes it's too much and it doesn't really add value to the clinical chain. And using evidence-based medicine and checking a registry of patients against the evidence and making sure that we're actually performing skills and tasks are up to the measure, that we're actually performing the way we want to perform to give people the best, sort of easiest, cheapest, fastest, most um, intervention-free outcome that they can get. The third one the third big effort we're doing is most people in the health system and most people in our 20 county area are what I call the walking wounded. We typically don't need a whole lot of health care. We have maybe one or two chronic conditions, maybe a little hypertension, a little hyperlipidemia, but we're basically healthy. And so the task there is to keep those people healthy and out of the system appropriately. If they have a problem with a sprained ankle, or if they have a cholesterol that needs to be brought into line, we need to understand that population and manage it, but keep them out of the hospital.
Sure.
Nobody wants to go to the hospital. Keep them in a place where they can do their work well. And so the health plan, very uniquely situated at St. Luke's with a network and a system and a plan, we have the ability to deliver, connect, and fund care. And I think it's one of the most unique scenarios in the United States today. We actually do a very good job of understanding our population on those 20 counties and then identifying them as they go through this process where we can have the biggest lever to work with them. So
So
that's in short what we're doing.
what you just described strikes one as a truly integrated, maybe aspirationally, depending on the maturity, but an integrated system that has the through line that you described, so that it's not a stutter step from I need care, I get some care, there's really not coordination, so I'm on my own. I don't know how it's going to be paid for. What are my benefits? Is that generally the takeaway from what you're describing?
100%. And it's kind of interesting. I was in a focus group the other day, about a month ago, and it was a bunch of people who were St. Luke's patients, and they were St. Luke's Health Plan members. So they were card carrying St. Luke's by two. They had these two cards in their pocket. And one of the questions came up about how they perceived our system. And it was interesting. We have this thing called On Demand, which is a virtual care offering for people who can't get into or don't want to go to their primary care doctor or have a problem that they need solution right now. And On Demand is what it is. A lady named Abby Lazinski's done a fantastic job creating that system. And what was interesting to me is two things. One is the patients perceive the St. Luke's On Demand as part of all of St. Luke's. And so when you show up at St. Luke's On Demand, there's an automatic connection with your primary care doctor or your orthopedist or whoever it is that is giving you care. And they
Okay.
work very hard to make sure that that connection occurs. And they think that we are an integrated system that cares and can manage care across the spectrum, which we aspire to be. And the second thing that was interesting to me is that when we compare that on-demand use versus some of the commercial on-demand like functions, those functions are decreasing. Those vendors are decreasing in their utilization while on-demand is increasing, which says to me that people want to engage with this integrated system in a way that we have been able to demonstrate we care for them across the spectrum of care. So it's very interesting.
Meeting people where they are in their journey and with their preference,
Exactly.
correct? What is the role then of the plan? You ran through deliver care, connect, coordinate care, and fund care. Obviously, the funding comes from the health plan.
Right.
What is the genesis of the plan, and how do you see that playing a role in this integrated system? Because, and the reason I ask is recently I heard a pretty well known speaker discussing Medicare Advantage as an example, and who was actually able to win in that space, and he called out specifically um, provider owned health plans,
Yeah.
right? Insurance entities. So that's what's behind the question. Just curious what the roadmap is.
Yeah, it's a good question. When I talked to Matt Wolf, who's the CEO for the health plan, and others at St. Luke's, the one of the interesting things that I in the interview process that I had come here is they said we didn't want to start a health plan. I was like, what? Well, you got one now. I was like, why did you do it? And they said, well, there are a couple of things that we could not do as a provider only, and try even working very closely with some of the health plans that we work with and collaborate with and enjoy working with. We can't control first dollar premium. Can't set rates in the community, and we can't figure out what the benefit structures are for these for the patients that we like to serve. And in order for us to be complete in our offering from cradle to grave services for the people in our community, we needed to have a health plan where we could control those things. And it is an arduous task to start a new health plan. It's capital intensive. It's an art that is a known art, but often not known to people who work in health systems. And the way the health plan works with the network and the system are beautiful because we have it's a beautiful conversation. If I have a person who needs care, I had this happen yesterday. I had a patient who came in. We have an ACA plan, which is the Obamacare. It's called Your Health Idaho, and she was on a fairly expensive drug, and she had just come onto our plan in January. And the drug was not it was an off formulary drug, and it was very expensive. And we looked at the copay structure for that, and this drug would have costed this lady with her copay $2,000 a month. In any
Great
other health
Scott.
plan, I, as a physician, reviewing this with a pharmacist, would have said denied, can't do it, no. You know what we did? We actually called the provider up and said, "Hey, look, here's the options that we have, and this drug is going to be $2,000 after copay for this patient. We probably think she's not able going to be able to afford that. Can we offer one of these three other alternatives that are a whole lot cheaper and probably as effective as that. And we went back and forth a little bit, and we landed with the patient on a drug that was affordable for this lady. And so that's the kind of relationship we have and the care we can give. And we listen to the need. We aren't just processing claims or processing denials and prior authorizations. We actually care about what care people get. We're not a for-profit health plan. We would like to make a profit someday, but we care about the people in our community, and we're able to do this sort of back and forth around this work that happens in that way. Another one, I was talking to a physician, Dr. Keller yesterday. He's a nephrologist, and we were talking about transplants and where to send people for transplants. And we have a network that is it's a broad network, but it didn't include one of the places that he has a very high level of trust in. And he was asking me, can we send these patients to this place? And I said, yes. I mean, we have a way of creating a contract with that specific entity. And if he has a high level of trust and he thinks it's the best place for our patients to go, and he's got data to prove it, which he does, then maybe we should figure out a way to get those patients to that place. It might be a little bit more expensive than the contracted network we have, but our doctors are telling us that the patient needs that place and we ought to listen. So I'm really happy about how this is all coming together, and I'm really happy about the potential it has over the long arc of our existence here.
So how are you identifying these opportunities? Does somebody raise their hand and say, "Hey, doc, I can't afford this $2,000 a month. I need some help," or are you using technology, or is it just old-fashioned comb through stuff?
Well, it's a little bit of all that. That particular case was one where it came through for a prior auth, and the particular pharmacist was we train people with the mission in mind here. And that particular pharmacist was on the ball enough to say, "Wait a minute, this is a very expensive drug. This patient is on an ACA plan. That means, and it probably has a subsidy. That means they're unlimited income. So we need to figure out a way that probably this patient's going to have to pay this thing. If we actually even approved this drug, the patient would have taken it because they didn't afford it." Another one, we do have some predictive analytics and some rule-based logic and some machine learning that when we get a population of patients like we have on the 1st of January for the ACA, we actually comb through those patients with analytics that predict who should we target for those frail patients or the high risk patients and so on.
Okay.
And they put us into a list of folks that we can work or call or reach out to their provider or them and do care case management. And sometimes the analytics are wrong and the patient's fine and stable. And sometimes we actually get people who really need help who haven't been helped. And sometimes they're in a program that is helpful and we're just noise to them. More often than not, we can find something that the patient needs that we can help with. And it's a real delight between the health plan, the network, and the system to be able to reach out to that patient and help them do the work that they need to have done.
So you said a kind of a triggering word to some of our fellow Medvallistas, and by the way, Dr. McEachern is a citizen, fine, upstanding citizen of the fellow community known as Medvale. Um, but you said pre-authorization, and that is the bane of the existence of many of our colleagues who have MD or DO after their name.
Yeah.
It is one of the things that gets in the way of the physician-patient relationship. It's, "Mother, may I do the right thing for this patient?" So why don't you unpack a little bit, and defend yourself, sir, of
Uh,
why there was a pre-auth involved?
it was interesting. The Idaho Physician Wellness Action Collaborative that I co-chair with Deb Roman, we started 7 years ago, and we started with prior authorizations. One of the things that we had a symposium in 2018, and one of the things that came out of that was that people hated PAs. Well, duh. Um, and it was interesting. We convened a table that came out of that symposium that was people who were PBMs, pharmacy benefit management companies, uh, all the major insurance carriers, and the major providers of care. And the first conversation almost ended in a shouting match where people were talking about they hated PAs. And one of the aha moments is one of my colleagues was a physician CMO said, "Hey, we hate PAs too." And the room went, "What? Why do you do it then?" I says, "Because that's the most blunt tool we have, and it's the only tool we have to do this work." Out of that came an effort with the Department of Insurance to look at the PA grids that we had, to coordinate those grids, and to decrease things that were useless, that didn't add value.
Hmm.
And we decreased our PAs by a third. And then we coordinated our grids so that a provider didn't say, "Is this a Blue Cross or a Pacific Source or a Select Health patient?" The grids were standardized enough so that that made it easy. Um, then what we did was took a real coordinated effort at making sure that we had the PAs that would actually add value. One of the oncology groups we worked with, we had in at full risk, so they were bearing the burden of the insurance and performance risk. They asked us to keep the PAs on some of the drugs because some of the things that they were doing inadvertently were very, very expensive for them and for the patient, and there were alternatives that were much cheaper.
So was it just a red flag for them to say, "Hey, we need to look at this," or was it them saying something else? I'm not
It was a
tracking.
red flag. It was one of
Okay.
those things that says, "This is an expensive drug." They don't, I mean, physicians typically don't know the price of drugs. I mean, they've got a lot of other stuff to think about. And this is one of those that's like, "Oh, if there's an alternative, maybe I should use it, or if it's the only drug I can use, I will use it, but I know it's expensive." At St. Luke's Health Plan, we have for medical, we have 12 PAs, that's it. We have 12. And those are on high variation, high cost, or problem prone areas that we think we can intervene in and add value. And we trust our physicians and those things that we were talking about, large case, the continuums of care, the least cost formulary philosophy. We design in systems that create value that we don't have to rely on PAs to do that.
Okay.
So that's a risk. It's also a benefit. What it means for us as a health system is we have to be able to identify and appropriately manage high cost care. And if we can't do that, that's a problem.
What you're describing, sounds like it may give you, in your role at the health plan, the opportunity to help inform, um, service lines, the actual delivery of care component,
Yep.
and one would think in return that the docs doing the work can help inform, you at the health plan as to what is really required, and maybe even down to benefit level of
Yep.
how things look.
Yeah.
Is that
Bang on.
on target or way off
No,
base?
no, bang on target. Well, it feels sort of funny because my role as CMO for the health plan is a very atypical role for a CMO. I feel like a man without portfolio almost. I mean, there's a lot of stuff that I do which is nuts on bolts, plan management, you know. But the real joy of this job is working with my physician colleagues, and they're manifold and great people who understand where disease burden comes and are eager to make changes in their practice of care and the process of care that adds value. We had a value-based care summit that my friend Jason Bronner, Dr. Bronner, hosted about a month ago. And one of the things that was sort of interesting out of that is for a long time, I think we have been scared to give doctors their data, you know, and
Right.
maybe that's because we've had some of the skin ripped off our back when we did that because the data is always wrong. There's always a signal in the data, but the data is always wrong. And what came out of that meeting to me was pretty amazing is the doctor said, "Give me the data with the names on it." You know, I want to see where we are, and I want to be able to understand where this unwarranted variation is, and I want to make it better. And that was I think that was a sea change in my experience with physicians in general, and it's exactly where we should be, which is we own that process, and we ought to be accountable to it, and we ought to create systems that support doing the right thing. We don't get perfect, but we're trying.
Well, here's a chance for you to show how wonky you can be because you talk about giving a physician data. Um, I know for a fact that you love to comb through data and take things apart, reconstruct it, look for patterns, look for signals.
Yep.
Um,
It is
but
an skill.
we've talked on this podcast before that healthcare largely is data rich, information poor.
Correct.
So what bridges do we need to cross to make it easier for someone providing care to consume real information that's actionable?
Yeah.
Uh, because again, the health plans in this nation sit on a whole lot of data, and they're sometimes reticent to share it with the people who are doing the most good sitting across from a patient. So
Yeah.
why don't you unpack your thoughts on that for us a little bit? See if we can find something that we can take forward.
It's a great question. I had a statistics professor named George Box from University of Wisconsin one time. I did a seminar with him, and he had this. He had two sayings. One is all models are wrong, some are useful, and so his corollary was all data is wrong, some is useful. And I think one of the things that we, as healthcare providers and data and analytics providers, get wrong is that there is data, all data is going to be wrong, but there is a signal in it. And then the question becomes, is there enough signal in that data for me to take action that's reasonable? Physicians act on data that's incomplete all the time. And we work in complex systems that are dynamic, and we watch. Part of the art of medicine is to watch what comes back when we throw things in there. One of the things that when I was at the Cleveland Clinic, I thought was a really brilliant way of doing this, because we are swimming in a bunch of information that's not really helpful, is that when they put their dyads together, so they had a physician working with a administrator, they also had a data and analytics person as a third leg of that stool. And so when the physician and administrator or operator would come up with a question, that data and analytics person would go back and get us enough information, enough signal help them with the work that they were doing. And one of the things that I think we could do a little better in our industry is to pair those people who work with data with the operator and the clinician in a way that is accretive to the getting the value down the road. Um, One of the areas that we've been working with, Kate Fowler is our CFO here, and she has a fantastic group of analysts who do activity-based cost analysis. And the spine team is very interested in creating a continuum that includes three distinct pieces of that continuum. First piece is how you get into it with primary care and ED. Second is physical therapy. And the third is the surgical intervention if needed. And the team of people that Kate has that work with this activity-based cost analysis have been giving us fantastic data that is actionable. It points us to a direction of where we need to go. It's valid and reliable and predictive enough for it to be trusted, and it corresponds with the continuum of care that we've lined out as a clinical world. And that's a model I think that we need to emulate better. Um, we'll always have better. Um, that's always going to be a struggle. But I think there's enough signal in most of the data that we have. If we were to pair it with an operator and a clinician, we would actually do quite well with that stuff.
What are the technologies that you believe are bringing the most value to healthcare today? Not just health plans, but to the
Healthcare.
people delivering the care, coordinating the care, funding care. What is the technology promise that you see on the horizon that is probably got the greatest value from your perspective?
So I think generative AI is going to be interesting. One of the things that physicians do is that are they hoover up a lot of data and then they order it in a way that makes some sense. And one of the experiments I think that's going on at St. Luke's winding its way into operations is using a way of listening to a physician interaction with the patient and then structuring that data into a problem-oriented medical record. The AI doesn't do a very good job of medical decision making or creating a problem list, which it probably shouldn't at this point. but it actually is fantastic at structuring the data in a way that is usable and useful for the doctor to be able to focus on more things than he or she would otherwise be able to focus. It takes away the task burden of listening and writing at the same time.
So more augmentation. Are you referring to ambient listening or
Yes,
ambient
the ambient
technology?
listening.
Okay.
Yeah,
Right.
and what that does is in aviation, there's this idea of task burden for a pilot. When what does automation do for a pilot when they go for a missed approach? Is it creates a margin of safety around how that airplane moves through three-dimensional space to a place where it's safe. And ambient listening can do that same sort of thing. It takes away a lot of the task burden that the physician has in the immediate physician patient interaction, and creates a way of structuring data that then could be reviewed and then prioritized. And so it's another task that not only saves time, it actually is actually more accurate in many cases than the physicians capturing the data because of the physician's time pressures, and it allows the physician to think more about the problems and the interactions that are in front of him or her. The second one I really like a lot is at the point of order entry. We're getting to the point now where we can actually adjudicate a prior authorization for a pharmaceutical drug. And in a system like Epic or other large EMRs,
Hmm.
once I type in a drug, there is an inference engine that can sit right along that order entry module that will go out and check to see if that's a covered drug. It'll go out to check which pharmacy has it and what the prices are for that patient. And what that would do is it would eliminate a lot of that back and forth around the PAs that we do have, and allow the patient and the doctor to have a conversation about where they can get this drug and what they're willing to pay for it. So I think that's another one. The third one is around data mining and data resources. We do sit on a lot of data. We've worked very hard at St. Luke's to create a data warehouse that is functional and not brittle. But we don't analyze the data that's in there to its fullest extent. And that's not just St. Luke's; that's any health plan.
Right.
We should figure out how that gold mine can be mined for the benefit of the patient and make care easier for the people who do that work. So I think those are three immediate horizons that I see along the way.
Well, we have a couple of traditions here on Megaphone. One, before we give you the last word, which is what we do, um, is to ask you for some travel tips. So if somebody is visiting your neck of the woods, what should they do, and what great restaurants should they be checking out?
Well, and it's probably a lot of folks know about Southwest Idaho and Boise, right? But I think one of the things that if I were to visit that place for the first time, what I would do is take a ride up to Stanley, go up into the Stanley Basin, and then if you've got a little bit of time, I would actually do it so that you would stay a night in Stanley, and
Okay.
then the Stanley Bakery in Stanley has the world's best sticky bun. Or not. So go to
Okay.
go to the Stanley Bakery and eat a sticky bun, cinnamon bun, and you got to get there early because the line's at the door, and it's a great place. The if you have if you can put shoes on and walk that area around Stanley, or even a little bit further to the east, the White Clouds, it's an unbelievable area. It's the nation's largest roadless area in the 48 states. And it's a beautiful area. And you can walk a mile off the road and you'll not see anybody. And there's a lot of places to do that.
That's fantastic. So sticky buns at the Stanley Bakery in Stanley, Idaho,
Yep.
and then strap them on and take a hike.
Take a hike. Exactly.
Well, Edward, thank you so very much. We're going to give you the last word. What would you
And
like to leave us with today?
the thing that I'd like to leave you with is that the St. Luke's was formed by a crazy bishop named Bishop Funston about 120 years ago. And this guy was the bishop of Montana, Utah, and Idaho for the Episcopal Church. And he came along, and his mission was to create a better community for the people in that area. And he did. He started the St. Michael's Cathedral. He started the Boise School District. He started Boise State, and he started St. Luke's. And it was a duty that he had that I think is what we all ought to have, which is how do we make this place a little bit better than when we found it? And St. Luke's is allowing me to do that, and I'm eternally grateful for that. I think we ought to embody that further in our lives these days. Thanks for the time, Dave. It's been a pleasure.
Dr. Edward McEachern, thank you so very much for joining us on Megaphone, and hope all of you join us next time for the next episode of Megaphone from Medvale Media. I'm Dave Self. Be well.